All right. Well, hello everyone. Welcome to the very first pelvic ground rounds. My name is Adriana, and I am a doctor of physical therapy. I am very excited to be starting this program or these series of videos that will be covering some just pelvic health information in general. Today's topic that we will be discussing is it ortho or pelvic? So we will be covering the obturator internus today and how it may mimic low back pain and SI joint pain. So for those of you that are tuning in, this is our very first video ever. And my hope is to be able to do this on a weekly basis and cover some topics just very quickly. It's going to only take about 25 minutes to go over just snippets of, pelvic floor information. And the goal is to be able to just kind of help give you assessment tools, treatment tools, things that will help you improve your ability to treat patients that are coming through the door. Like I said, my name is Adriana. I have almost 12 years of experience as a physical therapist. All of that time I spent in an orthopelvic setting. So this was many years of me treating both patients that were more generally orthopedic, but I slowly and very just passionately went into treating patients with pelvic health conditions. I am currently in Southern California. This is where I have my practice, Vida Physical Therapy. I don't think you can see it very well. The angle of the camera is kind of iffy. But I have been here my pretty much my entire life, except for clinicals when it sent me away to other places. But in the city, which is about 200,000 or so people, I am only one of two pelvic PTs. There is one OT in the area. So we see a lot of patients. A lot of them walk through the door. A lot of people come see us, and so we're very happy and fortunate and grateful to have the work that we do. So, moving on to what we will be covering, and the reason why I even started this entire, you know, the pelvic ground rounds was because I am I love to teach, I love to talk apparently. And I am very involved in the health community in the area. I am also involved in, I in a lot of Facebook groups and a lot of just support groups in general. But the general consensus, I think, lately has been that it is a very uh, it's become a very popular topic. It's become, I think, a very popular thing to do, pelvic health, women's health, which is great. We need more. There aren't enough people. And so I think the number of providers that are treating pelvic floor conditions has really ballooned. And so a lot of people are going into it just kind of right away, very fast and furious. And pelvic health is, I think, one of those specialties where there's like a big learning curve. It's pretty wide simply because there are so many conditions. And there just isn't a very like girthy or very structured didactic and practical, maybe like program or way to go about learning pelvic health. And so a lot of the information is kind of piecemealed. And a lot of that information is great courses available. However, they are you kind of have to look for them. It's hard to know what you don't know. And they're not given year round, so you kind of have to wait for when they come up, and they can be expensive. And so your knowledge of pelvic health and pelvic floor conditions is going to be incremental and perhaps not very thorough the very first couple of years that you start practicing. So I wanted to do this, provide these pelvic ground rounds, which is kind of hard to say, um, because I want to just let you know what's out there. Okay, you may not even know. It's like, holy crap, I didn't even know that those conditions existed. and give you some practical tools, something really, really fast that you can do in the clinic right away so that you get better at what it is that you're doing. Okay. So one of the topics that I feel has come up so much because I am in the orthopelvic setting is that, you know, a lot of PTs are like, all right, this is a pelvic condition, so go to a pelvic floor therapist. Well, yes, absolutely for the pelvic conditions. However, there are some things that if you are just ortho, and not just, but if you are mainly ortho or mainly neuro or maybe pelvic health, there everybody there has a pelvis. So you can absolutely treat certain symptoms and conditions. There is orthopelvic, there's neuropelvic, there is pediatric pelvic. So um, you can combine some of these treatment approaches and assessments, right away. So anyway, the obturator internus is one that I feel anybody can treat, anybody can assess, and anybody can implement right away. Okay, so if there is an issue with the obturator internus, whether you're a pelvic therapist or not, you can treat it. Okay, so we know the Obturator Internus. So if you are a student, you already took anatomy, so you know that it exists. If you're already treating, then you know, of course, that it exists as well. But just really quickly to kind of cover what it is and what it does. It is one of the external rotators of the hip, the P-go-go cues. The attachments are the inner surface of the obturator membrane to the medial surface of that greater trochanter. It is responsible for external rotation, adduction, extension of the hip, and maybe some abduction and flexion of the hip. It blends with the twins, the gemelli, and I thought this was really, really important to a really important point to look at is that Paul Hodges, who does amazing research, through EMG data, one of the studies found that the obturator internus has its greatest activation during hip extension. So something to think about and make note of, especially for like your patients who are having some of those symptoms, either low back or the SI joint in standing, particularly running with some walking, and just kind of think about that. Then it's mostly activated in abduction, and then it has minimal activation in other directions. So important things to know about that muscle. Um, so why do we even think about the obturator internus and what, when would we think about the obturator internus? Well, think about who is walking through your door, okay? Just as an example, if you are in outpatient orthopedics, okay, you are going to be knee deep in lumbar spine pain patients, okay? That is like, I don't know, a good majority of the people that are walking through the door. Okay. A lot of them have that deep aching, pain right in the middle of the back. Maybe it's even unilateral, and then the telltale sciatic nerve sign, that it's going down the back of the leg. It's shooting down the back of the leg. All right, it's sciatica, low back. Let's treat it. And that's what it is. That's the orthopedic condition. It's a low back pain patient. Now you've been treating them. Okay, maybe they're already in your part of your case load right now. You've been already treating them for, hamstring length issues. So you're stretching that hamstring, you're stretching piriformis, you're working on range of motion, you're working on your nerve glides, and they're getting maybe better, but maybe not as fast as we would like. Low back pain is also very complex. So you may have to take a look at a few more points than just what we're talking about today, but that's a, a an episode for later. So, you're working with them already. You're working on the low back, and maybe they're getting better, maybe they're not. Okay. Or perhaps you have this other patient that is walking through the door. They're telling you it's their SI joint. Okay. They Googled it. They know it's their SI joint. They know it is, and you know it is because it's right in the middle of that glute. It's like runs down this way. It's deep, it's aching right in that buttocks. It's only on one side. It feels tight. It's piriformis. We are going to stretch it. Let's do figure four. The patient maybe is already doing some of those stretches too. They say, oh, I've been doing my yoga stretches where I do my pigeon pose and it feels really good for a while, but then it kind of rebounds and it goes back to doing what it's been doing, which is, just being a pain in the butt. So those are your two, you know, your two symptoms, your two type of people, and I'm simplifying this quite a bit, but you know what I'm talking about. These low back patient group and your SI joint patient group. And the reason why I picked those two particular, patient types is because the OI presents like this. Okay, so for the obturator internus, symptoms and referral patterns, this is what it looks like. SI joint pain. All right, so it refers to that SI joint area. And something to think about, or thinking about the SI, now that I've been practicing as long as I have, is that I don't know if there's really like something that truly, uh, truly just is pinpoint at the SI joint. Those ligaments are the true culprits of the pain. The more patients I treat, the more people I see, the more I see like, this is a really good referral pattern. It's just like everything intersects there. And so you kind of really have to peel the layers with the SI joint pain. So if you see that referral, it says, hey, say, SI joint dysfunction, maybe the SI, it's probably something else or a contributor for somewhere else. So, obturator internus symptoms or referrals, SI joint pain, deep buttock pain. Okay, so it feels really deep in there. You have posterior thigh distribution discomfort or pain. You've got deep pelvic aching. You've got groin pain. A lot of people have pain and tightness with hip abduction where they're like, I feel it right there deep in that glute area. Um, Provocation test may be even pain with hip flexion and external rotation, where they feel it right in that area of the SI. Okay, but they also have or may complain of increased pain with sitting for a long period of time, where it's like I have to kind of unload that side. Okay, or if they suddenly like turn to one side or the other, they may provoke some of that pain. Um, or if they do like a deep squat or something, they're like, oh, I feel it right in that area there. Okay, in that SI joint area, and probably even back as well. They may even describe having pain during or after a bowel movement, that deep aching discomfort. May describe pain at the glute or the lower back with penetrative intercourse, so sex, or they may be having some pelvic floor issues, some pelvic floor muscle tension, that sort of thing. Okay, so think about those symptoms. Okay, we talked about the symptoms of low back pain, the very, very just like clear telltale, low back pain, pain going down the back of the leg. We've got the SI joint group, which is that posterior thigh, and now we've got the obturator internus symptoms. So if I would have done a Venn diagram of low back pain and obturator internus symptoms, there would be a huge overlap. Okay, if I would have done it with the SI joint and the obturator internus, we would have had a major overlap as well. So as you can see, there are layers that we have to peel in order to really tell, is this only lumbar? Is this only SI? Or are there some contributions coming from the obturator internus? And now that I have been treating patients for as long as I have, I always try to clear the obturator internus with any of those. Well, with a lot of other patients as well, but specifically with those two types of groups because there is just such a big, huge overlap with those two. Okay, so if you were thinking, okay, well, I have a limited amount of time to assess this patient. How can I just kind of quickly think, okay, why should I or should I assess the obturator internus? And so, what would sway us toward the obturator internus? Well, if you have somebody who has low back pain, okay, or they're having some discomfort going down the back of the leg. But they don't have any paresthesias, so there's no numbness and no tingling. And this isn't to say that sciatic nerve pain always has numbness and tingling. However, if there is absolutely no numbness and tingling, think of, let's clear the OI. Let's make sure that there isn't any tightness or irritation or anything like that going on in that area. Okay. Any pain that is at going down the back of the leg, so that posterior thigh, but it isn't crossing the knee joint line. We know that the sciatic nerve, so if you have your low back pain patient who was told they, oh yeah, it's sciatica, it's your back and sciatica, um, but they don't have pain crossing down the back of the knee, or I mean, past the knee. And we know SI goes, I mean, the sciatic nerve goes all the way down that leg. Um, let's think about the OI. So now, okay, I've got this person. They were sent to me for sciatica, but they don't have any numbness tingling. They have pain in the back of the thigh, but it doesn't cross the knee joint line. Let's think about the OI. If their symptom type is also more like aching rather than just like straight shooting, okay? Um, unless it's with like twisting or a sudden movement, we're thinking maybe it's more OI, all right? Also, if you have a patient that has now told you that they have had pelvic floor issues in the past, okay? And I cannot stress this enough, and I'm going to be talking about this a little bit more in the next couple of slides. We need to ensure that we give the patient the proper space to describe all of the symptoms that they are feeling in order for us to properly move forward with our treatment plan, okay? So if we are moving quickly past those bowel and bladder symptoms, okay? And a lot of intake forms have, all of these. I mean, you've got your patient's rights and responsibilities. You've got like, who is your emergency contact? Like, we are so, girthy on a ton of other information. And then when it comes down to like, what are your symptoms? It's just like check marks of like the same thing, basically for everything. So you have that. Maybe you have an LEFS, maybe you have an oswestry. And there's just like one little thing that's like any bowel or bladder symptoms. Now, some patients are like, what the hell do I even need to talk to you about like my bowel or bladder? And they either bypass it, and then the therapist also bypasses it. Okay. So they're like, oh, they didn't see it on the intake, so let's move forward. All right. Sometimes when we're a little bit newer to treatment, so for a newer provider, it may be a an awkward topic to discuss. So um, I truly encourage you to not skip that because that is also going to tell you whether or not you should be assessing the OI and perhaps even more past that, okay? So don't skip asking about the pelvic floor conditions, okay? So if they have any sort of bowel or bladder involvement, absolutely think about also assessing the obturator internus, okay? And if they've already been kind of stretching and you've been stretching them and nothing is really improving or there's like a big rebound, then let's absolutely look at that OI, okay? So how do we look at that OI or how do we palpate that OI? And this is one of like the more fun, other than like internal pelvic floor assessment, like description of how to palpate. This is one of my more favorite things, palpations to describe, simply because and I can't remember who said this. I think it was Ramona Horton or somebody else, but they said, well, you palpate it, it's east of the anus. It's like, all right. It is very, very close to that rectal area. Okay. So there are two approaches. We're only going to go over the external approach because we aren't talking about any of the internal assessments because this is a short meeting. So side lying and supine, there are two ways to palpate it, but the most preferred is side lying. This is because it is the most ergonomic, okay? There are some videos out there on YouTube where the person is palpating the OI from the bottom up, and that is just not a good, I mean, in terms of like efficiency and ergonomics, it doesn't make sense to me. So you want to palpate it from the top down. All right. So that means that the person is going to be inside lying. All right. The treatment leg, or the leg that you will be assessing, is at the bottom, is down on the mat table. The non-treatment leg is going to go up into hip flexion, really try to tuck it up and have it rest on like a bolster or a foam roller, okay, so that they are nice and relaxed, because the next steps are not going to be very relaxing to them. You're going to have the bottom leg kind of straight, so the knee's going to be straight, the hip is going to be like a neutral, the knee should be a little soft, not like completely stretched out, and have them really close to the edge of the mat table or wherever you're treating, just so that ergonomically it's a little bit better for you as well, okay? You are going to actually follow your hamstrings all the way up to the ischial tuberosities, okay? And I say do this until you get really good at palpating the OI. You're gonna follow, you're gonna find those little knobs of the ITs, and then you are going to sync your fingers. So it's kind of like in this motion here, okay, a little sync motion. Cephalically and medial to those ITs, so to those ischial tubes, all right? And often, if you're right on it and it is like a culprit of some sort, that OI, the patient's going to say, that's something there, okay? If they don't say anything right away, make sure that you're actually on the OI. So have the patient bend that bottom knee a little bit more and then press the knee down into the mat table so that you activate and that OI, and that muscle should jump up into your fingers, and then that's how you know that you're in there, okay? That you're in the area that you're supposed to be. Um, so all right, now they're, holy moly, that is tight and I don't like it and it's uncomfortable. What do we do from there? So you want to treat it right in that same position, okay? So you want to melt into the tissue. Do not poke. If you are somebody that is heavy-handed, go back 50. Even if you're not heavy-handed, whatever it is that you think you are, dial it down like 50, 75%, and then work your way up from there, okay? Because the last thing you want to do is get their nervous system super riled up because you just poked them right by their butt, okay? Make sure that they are as relaxed as possible. So work on breath work versus telling them to just relax, because I think it doesn't work to just tell people to relax. If they could, they would. So you have to guide them as to what to do to get a little bit more relaxed. Like I said, keep them close to the edge of the bed so you can bend that knee, because that knee is going to act as a little fulcrum for you. And some patients can actively, externally and internally rotate that bottom leg. Sometimes you have to passively do it for them so that you can go ahead and do like a little active release or just like a little gentle massage. You can also um, you may have to position yourself a little awkwardly at first, but you'll kind of get, and I'll show you how to do so in the next couple slides, how to position yourself so that you can do that internal and external rotation on that hip, all right? You can also have them do like a little isometric external rotation into the table so that you can help kind of melt that tissue even more, all right? So this is kind of the way that I set my patients up. I have Dr. Nenny here, who is lying on the table, and I had her bring her knee up as high as she kind of felt comfortable going. There I'm palpating the ITs. I kind of follow the hamstring up a little bit, and as you can see, I found it with my right hand. I'm not super ambidextrous, but I'm pretty strong with my left hand and fingers, and so I melted into those ITs. I bent her knee, and then there I did a little external rotation and internal rotation so that we can get some relief in that tense area there. So get that knee up, make sure that you clear that space. It's going to look and it's going to feel like you're going up the rectal area there. You are not, but this is why it's really important to not just dig, okay? So that's one position there. Another position is in supine. Okay, so for the supine position, we have to make sure that we get even more ergonomically positioned. Okay, you can't do this on everybody. Some people just have more tissue there. Some and you can't really get into those OIs as well. For her and for me, luckily, I was able to get and find them really quick. And so you rest the leg like I have her here on your shoulder so that you can kind of maneuver that leg around if you needed or if you wanted or if they could tolerate it. And so I like to take the hip into just a little bit of flexion and extension. I actually go and do some rotations there as well. I like this position with the people that I can actually palpate the OI on because, oh my gosh, that stretch and that release just feels so good and magical. And I have patients that are like, uh, you know, whatever we're doing today, make sure that we at least get this done here. Okay. So it's a really, really great, efficient, and fast way to release that OI. Okay. All right. So for you to really get to, you know, do that differential diagnosis even before the patient starts talking to you, make sure that you have good intake forms, okay? We can get to the point a whole lot quicker if we ask the right questions, all right? So in your intakes, if they have SI joint pain or low back pain, ask them, is this a deep gluteal pain? Is it posterior glute? And is it like, I mean, is it like, well, it shouldn't be posterior glute, it should just be glute. Is it like a pinpoint area? You know, is it like right there? Are they having any paresthesias? If they're not, let's think about OI. Your provocation testing, or what is it that's setting them off? Is it with twisting? Is it with prolonged sitting? Um, that gives you a big, um, just kind of like idea of where to go. If it's a straight leg race and it's positive, then we know, okay, sciatic nerve with the back. It's really, really involved. If it's not really that, then maybe it's something else. And don't skip the pelvic floor questions. Okay, don't skip those. Like, is it hurting with BMs? Is it hurting with intercourse? Are you having any urinary incontinence on top of that? Because you'll help narrow down how you are going to approach this treatment plan. Okay, so make sure that on your treatment forms, you don't skip that bowel bladder section at all. All right, if you, I feel like if you do, you are going to miss a good portion of what actually causes low back pain. All right. So, very briefly, we went over a ton of stuff, and there's so much more that we can learn, that we can do for the OI. I have stretches for that you can give your patients. If you are interested in that, send me, you know, email me. I'm on Instagram, all the socials, but there is a lot that they can do at home as well. And there are so many other treatments that you can do for your patient that will make your patient love you forever. And I just covered two of them right now, really quick. But if you want some more of that info, just let me know. So just kind of big takeaways are assess the OI with any low back pain and any SI joint pain. Honestly, your patient may just be so lucky that they have both, that they have like a true low back issue, sciatica, and the OI is, giving them a ton of, issues, and the SI, ligaments are crappy because of the way that they're walking. So treat it all. Treat as much as you can. Be thorough in your intakes. Make sure that you're covering all of the stuff that we just mentioned, the paresthesias, the BM issues, the pelvic floor. Be gentle with your palpation. It is an area that is so vulnerable and it is so close to areas that most people don't get touched. So if you are somebody that is like a very pokey type of person, learn. Learn to be soft, learn to be gentle, learn to back off. Okay. And if you are unsure if the OI is involved, just assess it anyway. Okay. As you get better and faster with your assessments, you'll get better and faster with assessing the OI. It becomes just kind of part of your regular, assessment for these patient groups. So any one of the things that one of my professors before said is that if the tissue is healthy and not involved, it won't hurt. So if it isn't a contributor to your pain, it won't hurt. If it does, then you're onto something. So always palpate and just clear it. Okay. Um, really quickly, because pelvic, I think condition, but pelvic treatment in general has become a very like hot topic, a very, sought after population to treat. And I think it's great. We want to make sure that we are as prepared as possible. So mentorship matters. Um, and we can't really get it everywhere, right? Not everybody is an expert in pelvic health, and you may be in a place where you're the only person that can do it, and people get busy and they just don't want to mentor. So you've got a lot of stuff stacked against you as you are learning pelvic health treatment. Okay. If you need mentorship, there are a lot of mentors out there. And it's really important to, I think, do so right at the beginning, because patients now have more information at their fingertips. Okay. So they are going to come to you a lot more informed than they did 5 or 10 years ago regarding pelvic floor conditions in general. Okay. And they may have already seen another pelvic floor therapist in the past. So they have options now and they are able to compare. So the more prepared you are, the more you can stand out. Okay. And if you're not going to be taking insurance, or if you're going to be out of network and you're going to be, asking patients to pay you out of pocket, you want to be somebody that's worthwhile. Okay. So mentorship matters. And I say that because I provide mentorship. I love to teach. I've taken so many students in the last however many years. During COVID, I took millions because a lot of people kind of backed off and they weren't taking students and people needed to graduate. So I took a ton. Ever since then, haven't taken as many, but I still love to teach. So I started this pelvic mentorship program and just wanted to let you know that it exists. Like I said, I'm on all the socials, so pelvic edu. Be that physical therapy on Instagram. If you go on to pelvicedu.com, you can learn a little bit more about the mentorship that I offer. It's available one-on-one or a monthly program, so that you can get just a little bit more support and feel quite a bit more, I think, prepared and confident in your treatment. So contact me if you're interested, if you have any questions. I hope that you got something out of this, and I will see you hopefully next week. We will be covering our next topic on, is it ortho or pelvic? And I will be announcing what that's going to be, because I just forgot what it is, on my Instagram. All right, everybody, thank you so much for sticking around. I know it took a little bit more than 25 minutes because it's my first time around, and I will be a little bit more, I'll be a bit quicker next time around. All righty, thank you so much.